So as a cardiologist, what I've tried to do is take findings at the bedside that we know to be true in patients, but that we don't understand the molecular mechanism for, bring them back to the bench, try to understand the molecular mechanism with the idea that the next time I'm seeing patients again, we'll have a better understanding about what's happening with them. So starting with clinical data, there's a tremendous amount of clinical data that suggests that elevated aldosterone levels are associated with increased risk of heart attack and stroke. So here's one example from a French group that took 124 patients with primary hyperaldosteronism. So they have a tumor that makes too much aldosterone. Not surprisingly, they have hypertension, and matched them to 465 patients with essential hypertension. So also the same degree of elevated blood pressure, but without elevated aldosterone, matched for other things. And it turns out that just having high aldosterone in the setting of hypertension portends a 4-fold increased risk of stroke and a 6.5-fold increased risk of myocardial infarction. So those folks have really high aldosterone levels, right? It's primary hyperaldosteronism. What about in the regular population? So this was another study that took patients who were coming to the cath lab for elective percutaneous coronary intervention. So it wasn't an acute coronary syndrome. They took 800 patients and they measured their serum aldosterone levels at the time that they did the PCI, and then they followed them for 16 months. And it turns out that if you had an aldosterone level above the median, but normal, you had a 3.5-fold increased risk of cardiovascular death in the next 16 months, and a 2.4-fold increased risk of having another cardiovascular ischemic event in the next 16 months, compared to someone with an aldosterone level below the median. So aldosterone levels are associated with high risk of cardiovascular events, and that the opposite is also true. So if you look at any of the heart failure clinical trials, so this was EPHESIS, so that was patients who came in with an MI and some evidence of heart failure, standard of care plus or minus an MR antagonist of eplerenone. There was a mortality benefit, but if you look at the secondary endpoints, you almost always see this about 20% reduction in acute myocardial infarction, even if it was not powered for that endpoint. And all that was with very modest changes in blood pressure, so insufficient to explain that. So is it possible that aldosterone acts on the blood vessel to contribute directly to atherosclerosis and coronary events? So in order to understand that and take it back to the bench, we need to know, well, what is known about the mechanism of atherosclerosis, which in and of itself could be a multi-hour lecture. So I'll tell you in 1 minute what you need to know to understand the rest. So the normal endothelium, healthy endothelium lining the blood vessel is anti-inflammatory, anti-thrombotic, but when it becomes damaged by cardiovascular risk factors like diabetes, smoking, hypertension, the endothelium starts to express adhesion molecules on its surface. That's these little blue things in the cartoon. That allows circulating white blood cells that normally are just moving by to adhere to the endothelium, roll along the endothelium, transmigrate into the subendothelial space, where monocytes differentiate into macrophages take up lipids in the setting of hyperlipidemia and form these lipid-laden foam cells that form the atherosclerotic plaque. Those inflammatory cells recruit other inflammatory cells like T cells. They all release matrix metalloproteases. Those proteases can degrade the cap that sits over the atherosclerotic plaque. And what happens then is when a plaque that is blocking only, let's say, 50% of the vessel, like this one here, which is totally asymptomatic in a patient, ruptures and a thrombus forms, now it goes from a 50% occlusion to a 99 to 100% occlusion. And if that happens in a coronary vessel, it causes a myocardial infarction. If it happens in a cerebral vessel, it causes an ischemic stroke. And the presence of inflammatory cells has been shown in pathologic studies to be associated with a greater risk of plaque rupture. So more inflamed plaques are more likely to rupture. Even Wikipedia knows that. So Adam McGraw, who was in my lab more than 10 years ago now, wanted to try to model that in an animal model. So he did what he called, and this is his slide, the Cheetos experiment. So he took the classic apolipoprotein E knockout mouse, which develops atherosclerosis, even faster if you put them on the high-fat diet, which looks like Cheetos. So he put them on the Cheetos and he randomized them to aldosterone or placebo at a low rate that would raise aldosterone levels, but without raising blood pressure. And then 4 to 8 weeks later, he took out their aorta, stained it with oil red O, and what you can see is that the burden of atherosclerosis along the aorta is greater in those treated with aldosterone. The size of the plaques in the aortic root, where you can see the 3 leaflets of the aortic valve, is bigger, and the lipid content is greater. And importantly, he then took the aortic arch from the same animals, and you can see that the arch forms plaques at areas of branch points, just like in humans, digested that to a single cell suspension, and did flow cytometry to see how many inflammatory cells were in the plaque. And it turned out that if the mouse was treated with aldosterone, there was twice as many inflammatory cells in the plaque, and that included both T cells and myeloid cells. The converse is also true. So this is a paper not from our group that showed that if you treated ApoE knockout mice on the Cheetos for 12 weeks with a eplerenone or placebo, the plaques got smaller. And Elizabeth Moss, an MD PhD student in my lab, took a different mouse model of atherosclerosis and randomized them to spironolactone or placebo and did flow cytometry and showed that there's half as many inflammatory cells in the plaque when you treat with a mineralocorticoid receptor antagonist. So aldosterone makes plaques more inflamed, and our antagonists make them less inflamed. So we were interested in whether this was a direct effect on the blood vessel as opposed to the kidney or elsewhere. So just reminding you of the blood vessel, it has endothelial cells that line the vessel that are a single layer that are in contact with circulating blood. And that is surrounded by several layers of smooth muscle cells that can constrict and relax to change the diameter of the vessel and also contribute to vessel structure and stability. So when I first started, and I was still a postdoc at the time, we started out by just confirming that mineralocorticoid receptors are expressed in this is human aortic tissue, human coronary artery tissue, primary cultured smooth muscle cells from those vessels, and primary cultured endothelial cells from those vessels. So the receptor is present. So now I'm going to tell you a couple of stories. One about the role of mineralocorticoid receptor in endothelial cells, and then what does it do in smooth muscle cells. So starting with endothelial cells, I'm going to show you that the mineralocorticoid receptor contributes to the vascular inflammation. So Kate Lee Barrett-Mueller, when she came to my lab as an MD PhD student, she first generated a mouse where you could delete the mineralocorticoid receptor just from endothelial cells. So we could ask the question, what does it do? And she showed here in that mouse that when she took out the mouse lung endothelial cells and mouse heart endothelial cells, the amount of mineralocorticoid receptor was profoundly decreased with no change in the leukocytes. So then when Elizabeth Moss came along, she took those mice and so one with the mineralocorticoid receptor intact and lidonates with the endothelial mineralocorticoid receptor knocked out. So that's what this stands for. And actually, for the first time in our lab, she compared males and females, which most people don't do. And so she took males and females of both genotypes, put them on the Cheetos, and looked at atherosclerosis. And why males and females? So we all know that there is a sex difference in the incidence of atherosclerosis events. So this is just new or recurrent myocardial infarction or fatal coronary disease per 1,000 persons. And females are generally protected relative to men. They have a much lower risk. And then after menopause, it takes about a decade or decade and a half, females catch up to males and ultimately exceed males in the risk of heart attack and stroke. And the mechanism for those differences across the lifespan by sex are not well understood. So she did this experiment, and the first thing she did was look at atherosclerotic plaques. So here are the males with and without the receptor, and here are the females with and without receptor. And the most obvious thing is that the plaques in the females are bigger. So here's plaque size, and the plaques in the females are bigger. At first we were surprised, but then we looked in the literature, and it turns out in mouse models, all mouse models and many of the other animal models, the plaques in females are bigger. And this was determined decades ago. And based on that, actually, many people don't study female mice in atherosclerosis. And it's why most studies have been done. It's one of the reasons why most studies have been done in males. And in fact, we recently wrote a review article and also have done some data extraction from the thousands of patient papers doing atherosclerosis studies. And it turns out only 25% of preclinical studies on atherosclerosis include both sexes, and only half of those actually compare the sexes to each other. So some just do them separately or mix them together. And most show that plaques are bigger in females. So does that make it a bad model of humans? So we looked in the clinical literature, and in the clinical literature, most people do not separate out males and females either or compare them. But we did find this study of 1,600 carotid ultrasound studies that was done in a prevention clinic in Europe. And in general, women had a greater degree of maximal stenosis of their carotid artery, but men had a greater burden. So they have more of the area of the carotid covered by plaque, but the females have a greater maximal stenosis. But then when they looked at which of those correlated with outcomes, it was the global burden rather than the maximal stenosis, which makes sense, right? The more plaques you have that might rupture, the more likely one of them will. If you have one really big plaque, we know as cardiologists, it's usually not the really big plaque that causes people trouble. We can always squish that and then they feel better, but it actually is not what causes death. And then multiple studies using imaging models show markers of plaque instability like inflammation or lipid content are greater in males. So Elizabeth went on and looked at the arch by flow cytometry and looked at the number of inflammatory cells. And so first looking at the males in blue, what you see is that the mice lacking mineralocorticoid receptor in their endothelial cells only have about half as many inflammatory cells in the plaque. But then when she compared that to the females, so the intact females, so this is like a wild type, the females have half as many inflammatory cells as the males to begin with. And I don't believe that has ever been shown before side by side before this paper in 2019, which is really shocking to me. But also in the females, if you delete the mineralocorticoid receptor, there was no additional effect. So how might that be? So I told you that in adhesion molecules on the surface of endothelial cells mediate how those inflammatory cells can roll and adhere and then get into the cell. And you can actually visualize that and quantify it by intravenous microscopy. So Elizabeth did this. So she labeled all the circulating cells with fluorescence so you can see the cells. And then she activated the endothelium, and you could see in the dashed circle a cell that is firmly adherent, so it stays there in one place. And then you can see leukocytes rolling along the surface. Some are rolling slowly, some are rolling quickly. And in a normal vessel that's not been activated by anything, you see none of that. So she quantified the amount of slow rolling cells and the amount of adherent cells in the same groups. And what she saw was that, again, in males, there's a substantial reduction in slow rolling and firm adhesion. The females with the mineralocorticoid receptor intact have less leukocyte trafficking than the males, and the deletion of the mineralocorticoid receptor has no additional effect in females. So slow rolling is mediated by the adhesion molecule E-selectin. So she looked at expression of E-selectin in the vessels of those mice and saw the same pattern. And firm adhesion is mediated by cell adhesion molecules like ICAM and VCAM. So she looked at ICAM. And again, males without the mineralocorticoid receptor have less ICAM on their vessels. Females have less regardless of the receptor, and it's unchanged. So how does this all work? So I won't go through all the molecular biology because a lot of it was published in this paper in 2014. But what we ultimately showed is that, and we used human coronary artery endothelial cells, primary, that mineralocorticoid receptors, when they get activated by their ligand, go to the nucleus and they regulate expression of adhesion molecules like ICAM1 and E-selectin, resulting in more adhesion molecule expression on the surface, and that mediates leukocyte adhesion to the endothelial cells. We showed that the estrogen receptor, which is another steroid hormone receptor, when it's bound to estrogen, goes to the nucleus and actually interferes with the mineralocorticoid receptor action to regulate transcription of adhesion molecules like ICAM1. So in males, we think that mineralocorticoid receptor is driving adhesion molecule expression, making plaques more inflamed. In females, that is prevented. If you delete the mineralocorticoid receptor from endothelial cells in males, they make less ICAM1, they have less inflammation, their plaques are less inflamed. If you delete it in females, the mineralocorticoid receptor is already being suppressed, so there's no further effect. So that's what we think the mechanism is. And so going back to what we think is happening in people, we think that mineralocorticoid receptors in the endothelium are driving vascular inflammation. We know vascular inflammation leads to plaque rupture. We know plaque rupture is the cause of heart attack, stroke, and death. Perhaps this explains why people with high aldosterone have a very high incidence of stroke or non-fatal myocardial infarction. We also know that females, when they are young, have estrogen. Estrogen is suppressing the mineralocorticoid receptor from doing this, and therefore they have less events. When women become postmenopausal and estrogen goes away, their mineralocorticoid receptors in the endothelium become de-repressed, and they can start to express adhesion molecules. Well, that took a decade or two in males to make their plaques inflamed, make matrix metalloproteases, cause those to degrade the membrane and the plaques to rupture. So it takes some time for the females to catch up, but ultimately they do. Why females have more events when they get even older is something we haven't looked into yet. So now I'm going to switch to smooth muscle cells and what the mineralocorticoid receptor does there. So, and now we're going to go back to the bedside, and I'm going to focus on aging. So aging is the most profound and universal cardiovascular risk factor. So I always say this, every person in this room is aging as we speak. It doesn't matter what sex you are, what your national origin is, what religion you believe in. And in fact, when I'm done speaking, everyone will be older than when I started. And we also know cardiovascular disease is a leading cause of death, with cancer as a close second. But as we age, cardiovascular disease becomes by far the leading cause of death. And in those over the age of 85, half of them will die of cardiovascular disease. And cancer actually becomes much less of a substantial cause of death. So what happens as we age? So I would argue that essential hypertension is a disorder of aging. So we all know 30% of the US population has hypertension. Turns out very uncommon in young people, rises in incidence, in prevalence linearly with age, such that 60% of people over 60 have hypertension and 80% of the population over 80 has hypertension. So almost everyone will get hypertension, and it basically is a disorder of aging. We also know that blood pressure control is inadequate, particularly in older adults. So if you take people over the age of 60, which is most of the people with hypertension, for those who know of hypertension, they have hypertension, 52.5% are well controlled. And this is true in males and females. So it's not well controlled. And we also know from the SPRINT trial that the better we control it, the less likely people are to have heart attack, stroke, and cardiovascular death. So what about the role of the mineralocorticoid receptor? So it turns out that in patients with resistant hypertension, which we know is people who are on 3 drugs and still not controlled, and remember, half of people with hypertension are not controlled, MR antagonists actually work really well. So this was a study taking people with resistant hypertension and giving them a small dose of an MR antagonist, and they had a 20 to 25 millimeter mercury drop in blood pressure. So they're on 3 other drugs, we can't get their pressure down. You give them a little MR antagonist and their blood pressure plummets. So it's a good drug for resistant hypertension. We know it works in the kidney to regulate blood pressure, but it turns out there's some evidence, even in the clinical literature, that what's happening in the kidney is insufficient to explain all of the benefits. And so here's a study that was like a dose escalation study of eplerenone, a meta-analysis actually of multiples of those. And we gave a dose of eplerenone, looked for responders and non-responders, and then went up on the dose of the non-responders and looked to see if more responded, et cetera. And then they measured the change in serum potassium in those same people. And the change in serum potassium is a direct marker of how well the mineralocorticoid receptor is acting in the kidney, because when you block the MR and sodium is released, potassium is retained. And it turns out that how much potassium you retain did not correlate with whether you responded blood pressure-wise. So the responders are over here, and their rise in potassium is actually less than those that didn't respond. So there must be something else that contributes to blood pressure control. So we looked at mineralocorticoid receptor expression in the human vasculature with aging. So Jaime and Ching, 2 postdocs in my lab, they took human aortic tissue from many, many people, obviously at the time of death, and measured mineralocorticoid receptor protein levels and correlated that with age. And the red is females and the blue is males. And in both sexes, there's a highly statistically significant correlation between MR expression in the aorta and age. And then they grew primary cultured human aortic smooth muscle cells from these various individuals. And they looked at mineralocorticoid receptor protein expression in the smooth muscle. And if you compare what we're going to call adults, so in their 30s to 40s, to those that we're going to call aged, which is in their 70s to 80s. My apologies to anybody who falls into either of those groups. But what you can see is that there's a 3-fold increased expression of mineralocorticoid receptor in smooth muscle cells from aged adults compared to 30 to 40-year-old adults. And that's true in both males and females. So we wanted to know, what is mineralocorticoid receptor and smooth muscle cell doing in the blood vessel? How might it contribute to aging? So Amy McCurley, when she was in the lab, generated a mouse where we could inducibly delete the mineralocorticoid receptor just from smooth muscle cells. And here you can see using a beta-galactosidase reporter where the pre-recombinase is expressed, and you can see that in the kidney cells, there's no expression, but in the small blood vessels of the kidney. And here's a small arteriole in the heart, but in the heart cells, the mineralocorticoid receptor would be intact. And here's the aorta, and the smooth muscle cells are staining. So she then put telemetry devices into those mice and allowed them to age. And with those telemetry devices, we can measure ambulatory blood pressure in the mice. And so just as blood pressure rises with age in humans, blood pressure rises with age in mice, not quite as profoundly. And what you can see is that in mice lacking mineralocorticoid receptor in their smooth muscle, the rise in blood pressure with age was prevented. So since then, and this is published as long ago as 2016, we did a lot of work to try to figure out the molecular mechanism. And it turns out that resistance vessels constrict in response to rising pressure. And they do that by activating voltage-gated L-type calcium channels. And when the resistance vessels constrict, that increases peripheral vascular resistance and contributes to blood pressure, in addition to the kidney, which obviously also contributes to blood pressure. So Jen DuPont, when she was a postdoc in the lab, showed that in aging resistant vessel smooth muscle cells from mice, mineralocorticoid receptor expression is increased, and it acts as a transcriptional repressor of a microRNA. So that microRNA goes down. And for those who know about microRNAs, they regulate large numbers of gene expression coordinately. And it turns out that microRNA 155 targets CAV 1.2, which is the pore-forming subunit of the L-type calcium channel. So when the microRNA goes down, its target goes up. And this led to increased calcium influx into resistance vessels in response to L-type calcium channel activators, which includes pressure. And it turns out that the mineralocorticoid receptor also regulates the angiotensin type 1 receptor. So what that results in is that aging smooth muscle cells and resistance vessels have more L-type calcium channels and more angiotensin receptors. And so as stimuli for those increase, they have an enhanced response. And so she showed that vessels from aged mice constrict more to an L-type calcium channel agonist. They constrict more to increases in blood pressure, and they constrict more to angiotensin 2, and that leads to increased blood pressure with aging. So adding this to our growing list of things that aldosterone does in the vessel, besides promoting plaque inflammation, it also promotes vasoconstriction, which contributes to the rise in blood pressure with aging. So what else happens as we age? Our vessels actually also get stiffer. So this, you can measure vascular stiffness or aortic stiffness by measuring pulse wave velocity. So the velocity at which the wave travels down the aorta and back speeds up as the vessel gets stiffer. And that's because instead of expanding with every beat of the heart and then contracting and having a wave sort of slowly propagate, if it's stiff, then there's less expansion, and that basically the blood pressure wave goes more quickly. And so as pulse wave velocity goes up, it's a measure of increased vascular stiffness. And if you plot pulse wave velocity, so vascular stiffness versus age in humans, there's a linear relationship that is highly statistically significant. And this is important because vascular stiffness independently predicts cardiovascular outcomes. So this is the 10-year risk of heart attack, stroke, and cardiovascular death. And here's pulse wave velocity. So that is increasing vascular stiffness. And then each of these lines is at the same mean arterial pressure, because vascular stiffness also contributes to blood pressure and blood pressure to vascular stiffness. So to separate them, you took people with the same mean arterial pressure, so let's say 80. As their vascular stiffness rises, their 10-year risk of death goes up. Of course, as you take people with higher blood pressure at the same level of stiffness, risk also goes up. And that's true in females on the left and males on the right, but you will notice that the slope of the curve is much greater for females. So vascular stiffness independently predicts cardiovascular disease event risk, and the slope is steeper in females, so it matters more in women. So SK and Jen DuPont, when they were postdocs in the lab, measured vascular stiffness in the mice using pulse wave velocity, so the same way we measure it in humans, and they measured it in 3, 12, and 18-month-old mice. And I always tell my folks that if you don't study mice, if you take the age of the mice in months and multiply by about 4, that's the age in humans in years. So a 3-month-old mouse is teenager, a 12-month-old mouse is middle age, so 40s, 50s, and an 18-month-old mouse is old. So you can see that vascular stiffness rises with age in males and in females, a little later in females, which is also true in humans. And in mice lacking mineralocorticoid receptor just in their smooth muscle cells, the rise in vascular stiffness is prevented in both males and females. When we took vessels out of those animals and we looked at their structure, so we looked at fibrosis by trichrome staining, so that's the turquoise here, and you can quantify the amount of fibrosis. This is in the carotid arteries. You can see that vascular fibrosis increases with age, and that's prevented in mice lacking mineralocorticoid receptor in smooth muscle. And the reverse is also true. So SK took 12-month-old mice. So these are mice that, 12-month-old, these are male mice, by the way. So if we back up, 12-month-old male mice already have increased vascular stiffness compared to 3-month-old male mice. So he took them and he randomized them to placebo or a mineralocorticoid receptor antagonist and said, if we took a middle-aged mouse that already has vascular stiffness, and then we block the mineralocorticoid receptor, can we do something to the trajectory? So I'll tell you that the doses of spironolactone that he used did not change blood pressure. We measured that. But then we looked at vascular stiffness by measuring pulse wave velocity over time. And what you could see is in placebo-treated mice, as they age, there continues to be a rise in vascular stiffness. In those that were treated with spironolactone, the rise in vascular stiffness was completely prevented. And there's actually a little bit of a trend towards a decline, although that was not quite statistically significant with these numbers. But at 16 months of age, there's a statistically significant difference. So less vascular stiffness in mice that were treated with a mineralocorticoid receptor antagonist. And when we took out the carotid arteries, there was less fibrosis in those that had their mineralocorticoid receptor blocked. So once again, we spent a lot of time figuring out the molecular mechanism for that. And I won't go through all the details, although if there are people who are interested, I'm happy to talk about the detailed molecular mechanism at the end. What we ended up showing is that with aging, we actually have a new paper that just came out showing that the reason the mineralocorticoid receptor goes up with age is that oxidative stress and inflammation of the vasculature increase. And there's two transcription factors that are induced. Oxidative stress induces the hypoxia inducible factor, and inflammation induces the NF-kappa B transcription factor. And we showed for the first time ever that those two transcription factors directly regulate expression of the mineralocorticoid receptor. And so that's why it goes up with aging. And when it does go up, it turns out it suppresses a epigenetic writer. So an enzyme EZH2 that puts methyl groups on histone tails. And it turns out that when H3K27, so histone H3 lysine number 27 is methylated, the chromatin in that region is compacted and genes are not expressed. And so when you block this methyltransferase that puts methyl groups on, the methyl groups start to come off. When they come off, then the chromatin opens and transcription factors can combine to DNA and recruit histone acetyltransferases that put acetyl groups on H3K27. When it's acetylated, it allows transcription to occur in that area. And what we found is that with aging, H3K27 acetylation goes up, and mineralocorticoid receptor then comes and binds to target genes. And those target genes include connective tissue growth factor, which is a growth factor that regulates collagen synthesis. And it leads to increased collagen, which contributes to the increase in fibrosis that we see with aging. And it also increases expression of integrin alpha-5. Integrins sit on the membrane of smooth muscle cells and interact with the extracellular matrix. And so they contribute to stiffness by how tightly the smooth muscle cells hold on to their matrix. And by the combination of those two events, this leads to increased stiffness of the smooth muscle cell itself. So if we take the smooth muscle cells out and do atomic force microscopy, we can measure that they're stiffer with age. And we did that in human primary smooth muscle cells, they're stiffer, and also in cells from the mice as they age. And then actually, if you treat them with a mineralocorticoid receptor antagonist, the cells, or you have a mouse that doesn't have mineralocorticoid receptor and smooth muscle cells, their smooth muscle cells are less stiff. And then, of course, if the smooth muscle cells are less stiff, the aorta is less stiff, and vice versa. With increasing age, it becomes stiffer. So now I'm just going to give you a couple more examples of situations in which the mineralocorticoid receptor contributes to adverse vascular pathology, and then sort of put it all together to tell you, so why do we have this receptor in the vasculature if it does all these things? So the other thing that smooth muscle cells do is that they proliferate in response to injury. So for those of us who are cardiologists in the cath lab, we go and stick a wire and then a balloon into someone's coronary artery. We denude the endothelium, and when we injure the endothelium, the smooth muscle cells begin to proliferate. And when they proliferate exuberantly, that leads to issues like in-stent restenosis, which limits the benefits of our stent procedures. It also leads to smooth muscle cell proliferation that can lead to vein graft failure, so failure of other mechanical methods by which we try to treat patients. So here's an example of that. So this is the carotid wire injury model. So this is an uninjured carotid artery in a mouse, and these are infused with bromodeoxyuridine, so it stains cells that proliferate brown. And what you can see is that in an uninjured vessel, there's almost no brown cells. So smooth muscle cells don't proliferate in a healthy vessel. But when you injure it with a wire, just like we do in the cath lab, over the next 2 weeks, you see a lot of proliferation happens. So Jaffe Puthi, when she was a fellow in my lab, she was a cardiology fellow at the time. She did this experiment where she infused aldosterone, and you can see that the amount of smooth muscle cell proliferation increases substantially, again, with a dose of aldosterone that did nothing to blood pressure. And here we measure the amount of fibrosis in the vessel by trichrome. And so when you injure the vessel, it becomes more fibrotic. And again, that's enhanced by aldosterone. And then she did that same experiment simultaneously in littermates that had the smooth muscle cell mineralocorticoid receptor deleted. And what you see is that the aldosterone effect is completely gone. So it's mediated directly by aldosterone acting on the smooth muscle. And actually, even the degree of fibrosis in the vessel in response to injury was less, even without adding aldosterone, if you just don't have mineralocorticoid receptors in smooth muscle. So mineralocorticoid receptor in smooth muscle directly contributes to adverse vascular remodeling in response to injury. What about vein graft failure? So we know that when people have lots of blockages in their coronary arteries, we send them for coronary artery bypass grafting. 2/3 of the grafts come from saphenous veins that we then attach to the aorta to bypass the blockage in the vessel. But they're not very durable. So 10 to 15% of saphenous vein grafts are occluded at a year, 40 to 50% by 10 years. And it's been shown by many others in the field that when you take a vein, which is usually exposed to low pressure, and you expose it to really high pressure, the vasculature gets damaged, and it leads to inflammation and profound smooth muscle cell proliferation. It thickens the vessel. Part of that is probably beneficial, so it allows it to withstand the high pressure, but that also leads to the occlusion over time. So we were interested in whether the mineralocorticoid receptor contributes. So we did this extremely difficult, and I will never do again, surgical procedure. And by the way, I didn't do any of these, but we have a fantastic surgeon who works in our core facility. But he transected the mouse aorta and took a donor inferior vena cava from another mouse, and then sewed it end to end into the aorta. And in those mice that survived that surgery, which was only about half, we randomized them actually the day prior to surgery to placebo or spironolactone treatment. And then we looked at their the saphenous vein or the inferior vena cava 3 weeks later. And so I should add a picture here of what a normal vein looks like, because it's very thin and small and pliable, but they get profound. So this is, these really dark cells are inflammatory cells. So they get profound inflammation. And then this pink stuff is smooth muscle cell proliferation. And so the vessel becomes much more thickened, smooth muscle cells profoundly proliferate. There's a ton of inflammation all around the vessel in response to just putting it into a high pressure. But if we treated them with spironolactone during that, there's still some hypertrophy, which I think is necessary, but there's a profound, so there's a 70% decrease in the maximum grafted area. And when we looked at the amount of inflammation, there was also about a 70% decrease in inflammation. So I think potentially MR antagonists could be beneficial to promote vein graft patency. And then the last little bit I'm going to show is, I showed this once a long time ago, some of this work to some pulmonary ground round somewhere. And someone said, those arteries that you show with the smooth muscle cell proliferation look a lot like what we see in pulmonary hypertension, that there's all these smooth muscle cells and that it eventually occludes the vessel. I wonder if the mineralocorticoid receptor contributes to pulmonary hypertension. So Ioana Preston is a pulmonologist at Tufts Medical Center, and she was at the meeting and she decided she wanted to try looking at that. So there's a whole bunch of different models of pulmonary hypertension. She took first this one. You just expose the mice to hypoxia for 4 weeks and they develop pulmonary hypertension. So their RV systolic pressure rises, you can see it here. And their smooth muscle cells that are surrounding the small arterioles thicken. And she randomized them to placebo or spironolactone and showed that it prevents the rise in RV systolic pressure and it decreases the smooth muscle cell proliferation. And multiple other groups have since shown the same in multiple different pulmonary hypertension models. And also we've a bunch of tissue-specific knockouts have been used, endothelial, smooth muscle, macrophage-specific MR knockout mice. And the short answer is that they all contribute in different ways to this. But an MR antagonist is quite beneficial. And there is a large clinical trial funded by the NIH that's looking at MR antagonists in pulmonary hypertension. So let's put the whole story together. So yes, aldosterone acts on mineralocorticoid receptors in the kidneys to regulate sodium and water retention, and that definitely contributes to blood pressure regulation. Turns out there are also mineralocorticoid receptors in endothelial cells and smooth muscle cells of the vasculature. The endothelial cells, they contribute to plaque inflammation, which contributes to plaque rupture and potentially to the risk of heart attack and stroke. And the interaction between the mineralocorticoid receptor and the estrogen receptor may contribute to why females are protected, at least when they're young. Mineralocorticoid receptors in smooth muscle cells directly contribute to vasoconstriction by regulating L-type calcium channels, thereby contributing to rising blood pressure with age. And they also contribute to how smooth muscle cells respond to injury, either in the setting of aging, where it contributes to stiffness, after wire injury, where it contributes to smooth muscle cell proliferation and fibrosis, after vein grafting, where it contributes to the profound adverse remodeling of the vein graft, and in pulmonary hypertension. So as I, over 20 years, developed all of this, I would give this talk to people, and invariably, the first question people would ask is, why do we have mineralocorticoid receptors in our blood vessel if they do all these bad things? It doesn't make any sense. So I've been thinking about that over the decades since people started asking me, and every time I added more of these, they were like, well, now we really want to know why, because, so I thought back to why do we have mineralocorticoid receptors? So they evolved when the lungfish crawled out of the salt replete sea into a salt scarce environment. And so that's when the ability to make aldosterone, the gene, evolved. So now you can make this hormone that can act on the kidney to retain salt, which you need to do in order to survive in a terrestrial environment. But in terrestrial mammals, as they evolved, what was the leading cause of death? It was traumatic injury or infection, right? So the saber-toothed tiger, turns out, I've learned since, was a major predator of humans. And so when an early human had a bad encounter with a saber-toothed tiger but survived and has an injury and is bleeding, they will become hypotensive. The kidney will notice that. The renin-angiotensin-aldosterone system will be activated. MR in the kidney will start retaining salt and water. That takes hours to days to raise your blood pressure, right? In the meantime, whether or not this early human survives depends on having a strong mineralocorticoid receptor system in their blood vessel, because that will mediate vasoconstriction, which is important in the setting of hypotension. It will recruit inflammatory cells to the site of injury to address the saber-toothed tiger germs that were just injected into the finger. It will promote smooth muscle cell proliferation to heal the wound and fibrosis. And if there's a scar at that site, that's not something that's concerning, or if there was too much excessive smooth muscle cell proliferation locally at the site of injury, that's what you're looking for in order to prevent death. And if this early human had a strong mineralocorticoid receptor system and survived until the kidney could retain salt and water and restore blood volume, then that would survive to reproduce and pass on the strong vascular mineralocorticoid receptor system to its offspring. So is there any evidence that this is true? So this is a study from a group in Taiwan that follows 2,000 patients with primary hyperaldosteronism. So that's a lot for that disorder. And whether or not they had it because of an adenoma or bilateral adrenal hyperplasia, whether they had surgery or not. And then they looked at their risk of sepsis or septic shock. And if you have primary hyperaldosteronism, you have an 80% decreased risk of developing sepsis or septic shock. Now, that's a relatively rare thing to happen these days, but the point is that there's some evidence that having an overly active mineralocorticoid receptor system prevents death from infection. But death from infection, well, I guess prior to the pandemic, was not really what was killing most people. Fast forward tens of thousands of years, saber-toothed tigers are extinct. We don't normally die from traumatic wounds. Our greatest predator is lifestyle, right? So we live a sedentary, high salt, high fat, high sugar diet. And the issue there is that rather than injuring the vasculature locally at the site of injury, we now have damage to the vasculature everywhere, right? So diabetes affects the vessels everywhere, smoking, hypertension, hyperlipidemia. And so now we have diffuse vasoconstriction, which contributes to hypertension, diffuse inflammation, which contributes to atherosclerosis, diffuse fibrosis and stiffness, which contributes to rising vascular stiffness with age, proliferation of smooth muscle cells that leads to in-stent restenosis, et cetera. So I think, in fact, we just wrote a new review article that perhaps mineralocorticoid receptor is meant to be a system to coordinate the response to hypotension, right? So endocrine systems coordinate many organs that need to respond to a stress, and the stress is hypotension. And that hypotension could be from bleeding, low salt or dehydration, or sepsis. Those are the causes of hypotension. And in that case, there would be a temporary activation of the mineralocorticoid receptor, would raise blood pressure. The inflammation, tissue repair, and wound healing would be at the site of injury where you want it. However, in chronic diseases, there's a chronic and diffuse activation of the mineralocorticoid receptor, and that causes these disadvantageous outcomes. And therefore, until we can address our lifestyle issue, Maybe Ozempic will solve the problem, I don't know. But until we can address that, I think MR antagonists or blocking of the pathways downstream of MR antagonists could have tremendous benefit to prevent these chronic conditions that happen to almost everyone, right? Aging happens to everyone, and the impact of that almost everyone feels. So I tried to mention all the people that did the work, and I have lots of collaborators around the country and the world, and of course my funding sources, and thank you for your attention. I'm happy to take questions. Maybe I'll go back to here.
I was surprised that you see larger plaques in phenols, but there's fewer inflammatory cells, and that's independent of vascularization. So, what do you comment on why? What's the mechanism of enhanced atherosclerosis that actually increase inflammatory?
Yeah, so that's a great question. And to your point, right? So the plaques are like twice as big and have half as many inflammatory cells. So if you think about the density of inflammatory cells, they're actually way, way less in females. And so that would definitely fit with less risk of plaque rupture. So that's the observation that we see. So why is it? So I guess our evidence suggests that the mineralocorticoid receptor is driving the inflammation, and it's suppressed by the estrogen receptor in the female. So that's why they're less inflamed. Why are the female plaques bigger? We haven't studied that. There is some evidence in humans, and this is from people taking human like carotid endarterectomy specimens from males and females and doing single cell analysis, that maybe smooth muscle cell proliferation is enhanced in females. And so maybe those plaques are going to have a greater, right? If they don't have as many inflammatory cells, but they're bigger, well, then they must have more of something else, right? But so few studies look at males and females that there's almost no comparison either in animal models or in humans. So there's like little bits of data. So we're trying to look into that, but it's really unknown. Yeah, but there's a bunch of single cell RNA-seq atlases out now of coronaries or carotids, and they either are all male or they just lump them all together and they don't separate it. And so it adds to the noise without being able to tell. Almost never. I look now all the time and they never separate the sex. Wow.
Yeah, that was a great talk. I have two questions. The first is, you can't cover everything with the vascular biomarkers, those are the vascular pieces, but you didn't mention the heart. I remember when I heard the throat case, can you tell us about these receptors in the heart and gender-specific expression?
Yeah, so the MR is expressed in the heart in the cardiomyocytes. Also, of course, in the endothelial and smooth muscle cells that are in the heart, right? Also in inflammatory cells that go to the heart in response to stress, and also in fibroblasts. What I can tell you in terms of sort of how those different cells contribute. So the model that a lot of people use for heart failure is transverse aortic constriction. And the transverse aortic constriction model has been done with the mineralocorticoid receptor deleted from every one of those cells. Turns out if you delete it from fibroblasts, no effect on the outcome for transaortic constriction. And the cardiomyocyte had a modest benefit if you knock it out. But we did the smooth muscle knockout, and it turns out that if you delete the mineralocorticoid receptor from smooth muscle, so these same mice, and you do transverse aortic constriction, the ones without mineralocorticoid receptor in their smooth muscle, their ejection fraction is better, their fibrosis, perivascular fibrosis is less, and we even looked at heart failure, so they have less lung weight.
That's not just within
It's everywhere, but the constriction is you increase the pressure. So let's say there's some stiffness downstream. We did it in young mice too, where they're not. It's proximal. That's why we use that model, because now does that mean that the smooth muscle cells elsewhere aren't contributing to what happens? Can't say that. But so the point is mineralocorticoid receptors contribute. Many people think it's through the cardiomyocyte, which it certainly is, but I think actually the other cells contribute a lot. Now, sex differences there, we did it only in males when we did it. And all those other people who did it for the endothelial fibroblasts did it all in males, so we have no idea if the sex difference.
And you clearly know the effects on blood pressure, but we have a little bit of problem. Everybody uses mouse model to have lots of limitations, but It seems like there's pretty, as you suggested, a pretty negligible effect of those drugs on, I don't know which drug you gave, or the, say, clearing of blood pressure in mouth. We immediately has some effects. So is that a bit of a limitation there, or I guess it allows you to focus more on the non-blood pressure specific effects. How about general, in terms of generalizability?
Yeah, so the reason we use doses that don't change blood pressure is we were wanting to look at blood pressure independent effects. But I'll also add that in people who are healthy and don't have hypertension, MR antagonists don't lower blood pressure that much. Even in the heart failure studies, they lowered blood pressure about 3 to 5 millimeters of mercury. In people with hypertension, they lower blood pressure a lot, right? In resistant hypertension, you give a tiny bit of an MR antagonist, they drop their blood pressure 25 millimeters of mercury. So I actually think that they are poised to respond when needed, and they're induced in hypertension and so then in those conditions, they become a good blood pressure drug. Now, are mice different from humans in blood pressure regulation? Definitely. And in fact, blood pressure in rats is much more similar to humans. And people who study like real hypertension, especially renal mechanisms, the renal mechanisms in mice are quite different from humans, and the rats are much more like humans. So if you really want to go there, the rat is the model to do that in. So it is a limitation for sure. Someone in the back. No?
Well, while we're waiting, I have three questions.
All right.
So I'll just start. I guess the first one was, this is probably in your papers, but have you done overectomies on the mice, and does that then normalize the phenotype, I guess, compared to male mice?
So we have not done that. What we have moved to is directly deleting the estrogen receptor and actually doing it specifically in endothelial cells to try to really get at the mechanism. I think probably the traditional approach would have been like, there's a sex difference. So first we ovex the mouse and see if the sex difference goes away, then we give back estrogen and see if that's sufficient. And then if it's estrogen, must be an estrogen receptor, then we'll knock out the estrogen. But we just jumped to the directly. So we now have an endothelial specific estrogen receptor knockout and a double knockout that has no mineralocorticoid receptor and no estrogen receptor in the endothelial cells to try and tease out how those two receptors are working together specifically in endothelial cells to regulate. What's your next question?
Okay, my next question is, in women who are premenopausal versus postmenopausal, any difference in how aldosterone antagonists work clinically? So I guess does one have more of a response blood pressure wise?
Yeah, so based on our data, you would expect it to have a greater impact in postmenopausal women. First of all, if the estrogen receptor is really inhibiting the MR, then you wouldn't expect much of an effect. And then we also showed that mineralocorticoid receptor expression level rises with age in females, and so they have more of the receptor to block, and they don't have the estrogen receptor around. So that's theoretical based on our work. Most clinical studies in humans, which don't even parse out sex anyway, the MR antagonists are given to postmenopausal women, right? If it's given for heart failure, if it's given for hypertension. When do we give MR antagonists to young people? Polycystic ovary syndrome, they give spironolactone, but I don't know that people have looked at that. I think it lowers blood pressure in that population, but I also think they have higher blood pressure because of the impact of the PCOS. So there's not a lot of situations, and when we compare them, they're not the same situations, right?
I was just wondering if you saw similar patterns in people who have inflammatory disorders that aren't vascular specific, like RA and sort of other things. Is there an MR mechanism there that we can observe?
Yeah, I think that, again, based on what we know, that MR is driven by its expression by NF-kappa B, which is an inflammatory transcription factor that is profoundly induced in people with inflammatory disorders. You would expect there to be a benefit there. It has not been tested, to my knowledge, specifically clinically. I can tell you that there was just a paper published, which I was kind of excited to see, in HIV patients. So that they have sort of chronic inflammation, and they're also at high risk of cardiovascular disease now that they're living a normal lifespan. And so they randomized HIV patients to an MR antagonist versus placebo, and they looked at cardiovascular endpoints. And they had a decreased risk of cardiovascular endpoints on an MR antagonist, and they went on and did imaging, and I forget what imaging modality they used to look for vascular inflammation. And vascular inflammation was decreased in HIV patients that were treated with an MR antagonist. And then I looked for sex, and of course they did not parse it out by sex, but maybe not surprisingly, the study was overrepresented for males. So it was like 75% males. And so whether the females had a benefit or not, it's hard to know because they were all lumped in together. So there is some data that in inflammatory conditions, an MR antagonist prevents adverse cardiovascular events, but I don't believe there's a clinical trial in rheumatologic disease, although I think it's worth doing.
If it's induced by the B, is the MR expressed in leukocytes, and does it go to leukocyte?
Yes, so it's expressed in leukocytes. It's been shown in T cells, B cells, and monocytes, myeloid cells. And in myeloid cells, it's been shown that MR activation promotes the pro-inflammatory macrophage phenotype, so the classical M1 versus M2. And we have deleted the mineralocorticoid receptor from myeloid cells, and it decreases plaque inflammation, specifically in males. And it does so by regulating the ligand for the receptor E-selectin and P-selectin. So you can imagine that if you have an inflammatory response, like you're bit by the saber-toothed tiger, you want your endothelial cells to make adhesion molecules, you want your leukocytes to make the ligand for them, and they come together, and now you get inflammation. So yes, it's in leukocytes, it's induced by NF-kappa B, and it regulates the other side.
All right. I think in the interest of time, we'll wrap it up. I'll ask you my last question.
All right.
Thank you.
Thanks, everybody.
I had a very basic